some familiar faces. It's good to see some familiar faces on here. Sorry, I'm running later than I had expected to be. Just so I have a sense of who's in the room, if you could go ahead and chat in your name and where you're kind of working, that way I have an idea of who's in the room. So it's good to see you, Dr. Dickerson. It's been a while. Good to see you, Dr. Doan. It has not been a while. But Vasuki, Linda, Viviana, Andy, Nicole, just be useful to know who you are and where you're coming from, and I appreciate your being here for this ECHO presentation. Thank you, Viviana. Thank you, Dr. Alexander. Thank you, Dr. Dickerson. Thank you, Linda. Andy, you want to say something?
Yeah, it'll be easier for me just to tell you than type it. I am a research student in San Diego State, and I'm working with Dr. McDaniel.
It's great to have you here. Thanks for being here. So I'm Brian. I'm an addiction psychiatrist, and this is a talk on medications for smoking treatment. I don't have any financial conflicts. I am affiliated with ASAM. ASAM has a integrating tobacco use disorder interventions clinical guidance document. I'm not going to try to sell you on anything necessarily, and it's not a financial conflict, but it is sort of a conflict of interest. Thank you, Dr. Vasuki. Dr. Vasuki, where are you coming to us from? So I'll jump into the content, and then folks anyone who hasn't responded should feel free to chat in. And if you have any trouble seeing the slide deck or there's any gray windows or anything, just let me know so I can adjust. Thank you, South Valley Clinic. So most people who use tobacco products would like to change that, somewhere around 70%. They may not be ready to today, right? That may not be like a priority right now, but very few people with tobacco use disorder sort of intend to continue indefinitely. By very few, somewhere around 30%. However, without assistance, the quit rates are actually relatively modest. There's a more than 95% return to smoking rate after people stop. So in order for an individual to say stop, typically means multiple attempts, right? The thing is, don't quit quitting. And medication services more than doubles the chances that someone's going to quit. We as clinicians are on a team there's multiple influences on people who use tobacco products. This is the smoking cycle. Nicotine, or really any drug that you inhale, but nicotine in particular, works very quickly. It's close to 7 seconds after a puff a puff of a cigarette or a vape. People feel relaxed and good, but nicotine has a short half-life. What comes out comes down. People crave another cigarette and then smoke it again. And this is the smoking cycle in blue. It's this transition from the nicotine level dropping, craving, and using again. That's typically the part of the use cycle that gets interrupted by medication services. Now, medications are only part of it. There's counseling and support. There's the physiology, the tobacco and nicotine physiology, and then the habit. There's a bunch of behavioral strategies that help people learn to not have a tobacco use disorder. These include cognitive behavioral therapy. Actually, physician advice seems to have a particular role. Individual counseling for more than 4 sessions and more than 10 minutes a session appears to be important. Psychoed groups, peer support, there's age-tailored self-help materials and helplines. These are all things that help people learn to, or sort of unlearn their tobacco product use. Many folks on here are probably familiar with the 5 A's. The 5 A's are to ask about tobacco product use, to advise people to change it, and I usually recommend starting with the word change as opposed to the word quit, because for many people, they may not be ready to entirely give up tobacco. They might be ready to cut down or not use daily, or they might have different goals. But changing typically means reducing initially if somebody's not ready to make a quit attempt. Now, if somebody wants to quit, great. But typically advice, you don't start with quitting, because if someone says, I'm not ready to quit, you might miss an opportunity to identify and support somebody making a reduction attempt. And then assist in somebody's making that attempt. Assist in arranging somebody to cut down or quit, and then arrange for follow-up. The 5 A's. Ask, advise, assess, assist, and arrange. What has gotten less publicity is the 5 R's. The 5 R's are shorthand for motivational interviewing, which is to start with, what is the relevance of tobacco use? And this is from the patient's perspective. So I, as a clinician, might care mostly about cancer, heart disease, strokes. For them, or for somebody who uses tobacco products, that may not feel relevant to them. For them, it might be the way they smell, not being able to walk up some stairs, staining on their teeth, the impact of tobacco products on their pocketbook. Those are all things that for them, it might be, why tobacco product use might be most relevant. But understanding the relevance of tobacco product use from the patient's perspective is really important. Then, what's the risk that the patient sees of continuing to use? What are the rewards that the patient sees from a change attempt? And then what are the roadblocks they envision? And you repeat this each visit. I mentioned relevance because we can, as clinicians, oftentimes get very caught up in why somebody needs to quit smoking and sort of put those ideas and values and preferences on them, when in fact, we are so much better off understanding tobacco product use from the patient's perspective and how they contextualize it into their lives. Patients are so much better persuaded by their own, by the things that are in their minds rather than the things that are in our minds. Okay, so 5 A's, 5 R's. I work with patients with mental health conditions. Many folks around here do. And I always think it does patients a disservice when we put tobacco product use and social history on our notes. It makes it sound like tobacco product use is sort of non-medical. Hey, Erica, thanks for chiming in. I would remind everybody that particularly with conventional cigarettes, the stuff in the smoke includes polycyclic aromatic hydrocarbons that increase the activation of an enzyme in the liver called cytochrome P451A2. And cytochrome P451A2 is responsible for metabolizing like antipsychotics, antidepressants, anxiolytics, not all of them, but many of them. And there's a actually really useful chart developed out of Australia that reviews many med interactions with smoking. And this is relevant in a couple of directions. There are some patients that have prolonged psychiatric hospitalizations. And when they leave and they resume smoking tobacco products, say somewhat more regularly, the blood levels of their medications would drop because smoking induces higher medication metabolism. Or if a patient reduces or stops their smoking, we might notice that they begin to have more side effects associated with some medications. Again, it's not because of any changes in medication adherence, it's simply because their liver is now responding differently to their smoking behavior. And in mental health settings, and I say this as a psychiatrist, we usually don't document tobacco use disorder, even though we should. Psychiatrists tend to refer to quit lines less than other physicians and clinicians, and many substance use treatment facilities do not offer smoking services. So everybody here is now familiar with Kick It California. Here's the webpage. It was updated a little under 2 years ago. But if you're familiar with 1-800-NO-BUTS, this is the new version of that. They have an updated phone number, although 1-800-NO-BUTS still works. It just forwards to this number. The new website, rather than No Buts, is Kick It California is the new website, and this is the new branding. So let me get into the medications. There's 3 molecules that are FDA approved for tobacco use disorder: nicotine, varenicline, and bupropion. Now, nicotine comes in a few different formats: patches, gums, lozenges, inhalers, nasal sprays. Varenicline is a pill you take twice a day, and bupropion is a pill you take typically once a day, although there are twice a day versions of it. Those are the 3 molecules that seem to work. Here is the chart. I'm not going to go through in a lot of detail, but it's in the handout. And thank you to Brianna for distributing the handout. That includes the 5 forms of NRT. So gum, lozenge, patch, inhaler, and nasal spray, and then bupropion and varenicline. Knowing nothing other than what we've already talked about, which of these medications for tobacco use disorder is best?
Whatever the patient wants.
Thank you, Dr. Down. The best medication for smoking treatment is the one the patient takes. It's the med the patient takes. There are a number of studies, sort of comparative efficacy trials, looking at for patients that take meds, which is better, which bypasses, I think, the critically important question, which is what meds does the patient want? It does not matter how strong the patch plus the gum or lozenge is if the patient doesn't take the patch or gum or lozenge. It does not matter how well varenicline works if a patient won't take pills. right? So patient preference, I would say, is the dominant factor to determine which medication is best. It's the ones the patient takes. Now, we do have a recommended medication strategy, and spoiler alert, it's combining multiple types of medications, but it's that I look at it as the menu of options. Right? The menu of options includes NRT plus or minus bupropion plus or minus varenicline, right? They could all be used. And we pick a medication strategy that is aligned with what the patient's going to do. Patient says, I won't take pills. That takes bupropion, varenicline off the table. I won't take anything other than pills, right? Then that takes a patch and other forms of NRT off the table. So just to be clear, we start with what the patient is, patient preference is like the most important thing. Now, not every clinician is familiar with all the medications, so I'm going to go through the meds in a little bit of details to make sure that we're all equally familiar with meds. Not every patient can take meds. There's some medical contraindications for some patients. And then if a patient has done really well on a med in the past, point to using it again. If a patient has done really poorly on a med in the past, it would speak against using med again. Bupropion in particular can help avoid weight gain. It can help with depression. So it's something to consider if a patient is concerned about weight gain or has a history of depression. Here is a comparative effectiveness chart from coming up on, it's 9 years ago, but coming up on 10 years ago, looking at combination NRT, the patch plus or gum or lozenge, which seems to have the highest effect of any med combination compared to other med combinations. And the point is, med combinations tend to work better than single meds alone. So that's why the DHS or LA County DHS expected practice on treatment of tobacco use disorder really recommends starting with a med combination. And med combination in some ways makes sense. Looking at the data, right, the LA County Department of Health Services prescribes typically the patch alone as the treatment for tobacco use disorder. And I sort of feel like that does patients a disservice because sure, a patient might put on a patch, but the problem with the patch is it takes a couple hours to get to the steady state. I mean, just look at the nicotine blood level after putting on a patch. 120 hours, you're finally at a blood level that might make somebody with tobacco use disorder feel comfortable. Many people with tobacco use disorder are not going to wait 2 hours to get comfortable. So that's why having a short-acting, faster and shorter-acting version of nicotine, such as the gum, lozenge, inhaler, or nasal spray, in combination with the patch, makes sense because it more closely mimics the natural blood level you get with cigarettes, which is a fast onset and kind of slower. I mean, nicotine does not have a huge half-life, but it's kind of slower offset. You can use the gum, nasal spray, inhaler, or lozenge to get that peak effect that somebody might be missing. So in other words, when somebody has a craving for cigarettes, rather than reaching for the cigarette, you're giving them another tool, another shorter acting version of nicotine that they can use on top of the patch to get their nicotine blood level up, and that can help them learn how to get through their day without smoking. So the patches come in 3 strengths: 7s, 14s, and 21s. We estimate roughly 1 milligram of nicotine per cigarette. So if somebody smokes a pack a day, a pack has 20 cigarettes in it, they get a 21 milligram patch. We dose the patch to meet or even a little bit exceed the total milligrams of nicotine somebody takes in, and we estimate again 1 milligram of nicotine per cigarette. So 20 cigarettes a day, full pack, 21 milligram patch. Half a pack, which is 10 cigarettes a day, gets a 14 milligram patch. A quarter pack, 5 cigarettes a day, gets a 7 milligram patch. We sort of dose it to meet or exceed the amount of cigarettes. How do we dose with somebody that vapes? Well, you have to know something about the vape pod. So there are weaker vape pods and stronger vape pods. If you just see how long does it take for somebody to go through a vape pod, that's how you can estimate the number of nicotine, the amount of nicotine takes in. So if somebody is using a 50 milligram vape pod and it lasts them 5 days, that's 10 milligrams a day, they get a 14 milligram patch. If somebody is on that same, 50 milligrams of nicotine a day, and it takes them, 2 days to go through it, they should probably get a 21 milligram patch, and you can either combine that with a 7, right, so that they get like 28 milligrams a day, or supplement with higher dose, shorter acting NRT. 2 packs a day, 21 milligram pack, like you continue to dose up. I recommend people put on the patch when they wake up and take it off before they go to sleep. There's not a lot of huge advantages to wearing the patch while you're asleep. It can reduce morning cravings for tobacco product use. Interestingly, it doesn't seem to actually reduce morning smoking, or I should say wake time smoking. And it can cause nightmares. And so because you get this adverse effect, which is nightmares, not a ton of benefits with wearing a patch while asleep. That's why I recommend you just take off the patch before somebody goes to sleep. The patch can cause skin irritation. The skin irritation is not from the nicotine, it's from the adhesive that's used to get the nicotine patch to stay put. If somebody is having a skin irritation, they should switch brands because different brands have different adhesives and different brands have different adhesives, and a different adhesive might be associated with not having skin irritation. Because people, let's say you don't wear it while you're asleep, will wake up in nicotine withdrawal. So it's recommended to have gum or lozenge or inhaler or nasal spray near somebody so that they have an alternative to in this case, an alternative nicotine product to use rather than the patch when they're having a craving. The patches do come off during a shower, they come off with swimming, they come off with sweat. So that means somebody might need multiple patches throughout their day if they go swimming, shower, or sweat. Or easiest thing is to put on the patch after a shower, assuming you shower when you wake up. Or you can also wrap the patch in surgical tape, and that can help keep it on even if somebody gets wet. We recommend to start it even if the person's not stopped. All right, starting the patch helps people reduce their nicotine product consumption. There's just like a couple of elegant studies looking at blood level of nicotine and tobacco product use. And as the blood level of nicotine goes up, tobacco product use goes down. Doesn't go to zero, but it does go down. So you get somebody's blood nicotine level up, it can support them in making a reduction attempt. And we recommend combination NRT. I never prescribe the patch alone unless the patient says, I'm only going to take the patch alone, in which case patient preference trumps everything else. But the standard offering is the patch plus the gum or lozenge, actually plus bupropion. We go full combination, and I have a chart that goes through that. The gum or lozenge come in two strengths, 2s and 4s. The 2s I usually use for people with kind of lower levels of nicotine use, half a pack a day or less. 4 milligrams is half a pack a day or more, but oftentimes I'm just saying, hey, we've got weaker and stronger ones, which would you prefer? The gum works if you chew it, because that gets the kind of nicotine in the gum kind of on the outside of the gum, and then pushing against your cheek. Pushing it against your cheek is really important because pushing against your cheek is how the nicotine is absorbed into the bloodstream. So if you sit there and chew it, nicotine will get into the saliva, but the saliva is swallowed and it digested without being absorbed in the stomach. So in order for people to really get the nicotine out of the gum, you chew it, but then you park it against the cheek, and it's the connection between the gum and your cheek is how the nicotine is absorbed. Nicotine has kind of a peppery taste. So if somebody chews the gum and it's against their cheek and the pepper taste goes away, they need to chew it again to kind of refresh the nicotine on the outside of the gum. And a couple cycles of that, the nicotine taste will, or the peppery taste will fade, and you know the gum has been spent. Same principle with a lozenge. You don't chew a lozenge, but you swirl it against your cheek, and it's the combination of the lozenge against the cheek is how nicotine is absorbed. If somebody tries to swallow a lozenge or chew and swallow a lozenge, they just won't feel any nicotine in their body. The inhalers and nasal sprays do deliver nicotine, although I have patients that vape, and when they use the inhalers, it's just taking dry air through a wick. Like, it doesn't have the same like flavor or experience as vapes. Nasal spray, I've had patients use to say it's very intense and causes nasal congestion. So there's some disadvantages with that, but for a patient that really prefers the inhaler nasal spray, I'll absolutely do that. Sometimes with Medi-Cal, you have to put in a treatment authorization request. I think with Medi-Cal Rx, both are covered, but if in doubt, you could put in a prior auth if needed. What about bupropion? So bupropion metabolizes to hydroxybupropion, and it makes the nicotine receptors in the brain less responsive to nicotine. It doesn't seem to interrupt the effect of nicotine replacement therapy and can actually have an added value. It is, of all the medications, the most complicated in terms of side effects and contraindications. So bupropion is an antidepressant. It goes by the trade name Wellbutrin, and a bunch of patients take Wellbutrin. It used to be marketed under Zyban, Zyban was bupropion SR, which was a twice-a-day medication. We now have a Wellbutrin extended release, which is a once-a-day medication, and there's really no evidence that the once-a-day works any poorer than the twice-a-day. So for Wellbutrin, typically we just prescribe it once a day, usually at 150 milligrams a day for a few days, just to build up somebody's tolerance to it, and then up to 300. You can safely start it even if the patient is still smoking. You don't have to have stopped smoking for the person to benefit. But when I said contraindications, it can cause seizures, so we don't recommend it in people with seizure disorders. In people with bipolar disorder, and I don't mean like methamphetamine-induced mood disorder, I mean like true bipolar disorder, it can induce mania. So I don't dose patients with true bipolar disorder unless they're also on a mood stabilizer, in which case you can use it. And then people with a predisposition to seizures, like people who are about to stop taking their benzodiazepine or stop drinking alcohol abruptly, there's some evidence that can cause seizures in people with active bulimia, are again relative contraindications. It is a really activating antidepressant, so it can cause tremor, insomnia if you take it too later in the day, and jitters, but you can safely combine it with nicotine replacement therapy. This is just the area under the curves of immediate release, sustained release, and once daily bupropion, and the areas under the curves are comparable. So I usually dose bupropion extended release, 300 milligrams. Here's the precautions and contraindications that I went over earlier. And then lastly, varenicline. It is a high affinity partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptors. It does cause nicotine activation. So you do get a nicotine effect, but it blocks nicotine from binding to the receptor. So it's sort of like the buprenorphine of tobacco use disorder, right? Like you create this nicotine effect, but if you were to smoke on top of it, it would just block that nicotine from binding to the receptor. When I have patients with varenicline, the way that they describe it is they say, yeah, it's just smoking doesn't taste right anymore, right? I'm not really feeling it anymore. And I had this one patient, well, I'll get into patient stories in a second. It's when you titrate up and taper off. If you just abruptly stop it, patients will go into nicotine withdrawal. The clinical trials show that if you could only pick one med, this would be the medication, right? It's the most effective agent when used as monotherapy. And the usual titration is 0.5 milligram once a day for 3 days, 0.5 milligram twice a day for 4 days, and 1 milligram twice a day thereafter. The side effects are nausea, sleep disturbances, headache, farting, constipation, and taste alteration. There used to be a black box warning that it caused anxiety, depression, and suicidality. And there are patients who do have neuropsychiatric reactions, although it's not clear to me that that's actually from the varenicline, because quitting smoking is actually quite stressful, like irrespective of whether meds are used or not. Suicidality, depression, anxiety goes up during smoking cessation. What's interesting is if you can get somebody through a quit attempt, people's mental health dramatically improves, right? Their depression goes down, their anxiety goes down, or their depression improves, their anxiety goes down. So there are real neuropsychiatric benefits of quitting smoking, but the quit attempt is stressful. So this is the article from 2019, right? Irrespective of medications for smoking treatment, people who use tobacco products are more likely to experience neuropsychiatric events while quitting. This is highest for people who identify as white and who have current anxiety or prior suicidal ideation. And again, highest in people who have a psychiatric history, who identify as female, who are younger, and who have a greater severity of tobacco product use. When compared to other things, I mentioned varenicline might be the most effective single agent. I actually first learned to prescribe varenicline in a clozapine clinic with people with serious mental illness, and it seemed to work, right? It was well tolerated, and not associated with poor mental health outcomes. And then there's a very large Eagles trial essentially saying that although the mental side effects of varenicline are not absent, right? They're still there. Most people who have these side effects did not have psychiatric hospitalization, and that the benefits of stopping smoking clearly outweigh the risks. So here's the chart I went through earlier. Not everyone that uses tobacco products uses them every day. So if somebody's using tobacco products PRN, then they get a PRN med. So PRN gum or lozenge, if they are, and then depending on the number of cigarettes they typically use during a smoking event, if it's 2 or fewer, they get a 2 milligram gum or lozenge. If it's 3 or more, they get a 4 milligram gum or lozenge. If somebody's using daily, then if it's a quarter pack of cigarettes or less, they get a 7 milligram patch plus 2 milligram gum or lozenge plus bupropion XL. That's the menu. Now, if they don't want to take any component of that, that's fine, but that's what's on the menu. This was developed in the LA County Department of Health Services that really wanted a patch-first approach because patches are much cheaper than varenicline. So the expected practice read, patch, gum or lozenge, bupropion, but if the patient doesn't want the patch or doesn't do well on the patch, then varenicline, gum or lozenge, bupropion, right? So you can really use all three forms, varenicline, gum or lozenge, bupropion. You might ask, what about varenicline plus the patch? I usually don't combine those. There are a couple studies showing some benefits, and then a couple studies showing that there's really no benefit to combining them. And just pharmacologically, right, the patch is a steady stream of nicotine, and varenicline is a medication that blocks nicotine. So it's always been counterintuitive to me to sort of combine them. If a patient really insists on that combination, I'd do it, but I just haven't had a patient really take me up on that yet. A half a pack a day smoker, 14 milligram gum or lozenge plus 2 or 4 milligram patch or gum plus bupropion, varenicline or varenicline standard dosing plus the gum or lozenge plus bupropion. A pack a day smoker gets a 21 milligram patch plus the stronger gum or lozenge, 4 milligrams plus bupropion. A 2 pack a day smoker gets 2 20 milligram patches plus the 4 milligram gum or lozenge plus bupropion. A couple other questions that come up. What if the patient is getting too much nicotine, right? They say, I smoke here, but they don't smoke here. They smoke here, and now you're giving them too much nicotine. What will happen is they will begin to come flush, their heart rate will go up, their blood pressure can go up, and they get nauseated. And then actually nicotine at that point becomes quite aversive. So typically people will stop smoking at that point because it's made them feel ill. And then you would just have the patient remove the patch or, stop using whatever nicotine products. And nicotine's metabolized pretty quickly. So whatever toxicity would pretty quickly resolve within an hour or two. But that's one of the advantages of NRT is because nicotine's relatively short acting, it's hard to sort of incidentally overdose on it. Like nicotine will become aversive, people will stop using the gum or lozenge and should take off the patch if they're really not tolerating nicotine well. And truthfully, most patients served in the public sector, including people with mental illnesses, need higher doses for longer durations and in combination compared to people without. What about pregnancy? So during pregnancy, psychotherapy is first line. Now, NRT may be seen as less effective during pregnancy, and so the U.S. Preventive Services Task Force does not recommend any medication during treatments during pregnancy, but I have a caveat to that, which is if the patient is doing, you've referred them to the California Smokers Helpline, you're doing psychotherapy, you're supporting them in their quit attempt, and they're still smoking. Conventional wisdom is NRT is safer than smoking, and there's really not a ton of harms associated with the NRT. The usual stuff, skin irritation and some elevation of blood pressure. But again, studies evaluating harms are limited. And I'd rather have a patient getting nicotine through NRT than getting nicotine from smoking. If somebody is going to if you're going to dose NRT during pregnancy, just recognize that in later terms of pregnancy, the metabolism of nicotine becomes accelerated, so the doses need to go up. There's really not sufficient evidence to support initiating varenicline, bupropion, or electronic nicotine delivery systems or ENS devices during pregnancy. During breastfeeding, we recommend, unless there's a reason not to, that new mothers breastfeed their children, and the use of NRT while breastfeeding is way safer than continuing to smoke. So if somebody is continuing to smoke, NRT is the treatment of option during breastfeeding and breastfeeding is not contraindicated. What about if somebody's in an addiction treatment program? Some of the evidence around addiction treatment is if people quit smoking while they're in addiction treatment, they actually do better with their addiction treatment, right? Like their alcohol use disorder or their alcohol use disorder or methamphetamine use disorder or cannabis use disorder gets better when they stop smoking. So there is evidence that tobacco use disorder assists in tobacco use disorder treatment assists in treating other SUD conditions. And going to addiction treatment, like 15% of people that use tobacco products stop using tobacco products. That's good, right? But 11% of people who go to addiction treatment who start as non-smokers start smoking, right? They develop a tobacco use disorder because tobacco use disorder is so common in addiction treatment. And the odds ratio for improvement, right? The remission odds ratio more than doubles when people quit smoking in addiction treatment. So, truly, smoking treatment during SUD treatment enhances the treatment outcomes. So the conventional wisdom of this person's not here for that, we should let them continue to smoke. We should absolutely diagnose and treat tobacco use disorder for any patient up for participating in a mental health or SUD treatment program. Do I recommend ENDS or electronic nicotine delivery systems as a tool? I think of electronic nicotine delivery systems as a harm reduction program, right? Like if somebody's not interested in medications for smoking treatment, but is looking to continue to use a tobacco product that might be less harmful, there's some evidence that ENDS products are less harmful. They still cause lung injury, right? Like, let's be clear, they are not safe, but they are safer than conventional cigarettes. So as a harm reduction strategy, sure. But I don't confuse electronic nicotine delivery systems as treatment, right? Because you can convert from a cigarette to a vape, but now you have a vape use disorder, right? And so how do you treat that? With meds, counseling, support, the same tools we use for tobacco use disorder. So as a harm reduction strategy, reasonable. As a treatment tool, it's not a treatment tool, right? It's just a less harmful way of taking in tobacco. Keep in mind, there's a lot of additives in polyethylene glycol, and there's no improve. Like people don't then transition to ends and then quit, like spontaneously quit ends. Like they still are now faced with the same quitting. It just instead of quitting cigarettes, now you quit a vape. This kind of wraps up the didactic part, but I do want to have a conversation with those here about your experiences. There's a federal website, smokefree.gov. There's the California Smokers Helpline, kickitcalifornia.org. There's a 12-step program, Nicotine Anonymous. Most of my material comes from the UCSF Smoking Cessation Leadership Program, and there's a coalition, Behavioral Health for Tobacco Free. I don't recommend light cigarettes or natural cigarettes. E-cigarettes are expensive, and again, they're safer, but not safe. And smokeless tobacco that causes cancer and is just as addictive. So those are the do's and don'ts. I think the key thing is being persistent. And just one sort of reminder, I had this patient, she had multiple mental health conditions, and I treated her with varenicline. And she went from smoking like a pack of cigarettes a day to 3 cigarettes a day. It was a huge win from my vantage point, a dramatic reduction. And she's like, hey, I'm down to 3 cigarettes a day. I was like, great. And then she was frustrated. But this is smoking cessation. I said, yeah, you're on a smoking cessation medication. She's like, but I haven't quit yet. And I had to remind her, well, you're right. Like you're on a med and the med helps, but you still actually have to quit. You actually have to like learn how to, like you have to like figure out how to get up when you wake up and not smoke. And let's say if she drinks coffee, drink coffee and not smoke, and get to work and not smoke, or get to, get around your day. Like you have to like relearn your day as a non-smoker. The meds will help with that, but you still have to quit smoking. So these meds alone don't make people quit. This is my email address if there's any questions, and conflict of interest alert. You're all invited to come to the addiction medicine meeting, which is going to be in Dallas this coming April. CSAM has a meeting coming up at the end of August in San Diego, which is much closer than Dallas. And the addiction psychiatry meeting will also be in San Diego this year in December. So with that, what questions do you have, or what clinical vignettes or cases should we discuss during this ECHO training session?
Thanks so much for the wonderful presentation. The resources you cited, those do have Spanish and other languages for patient materials as well. Do you know?
For Kick California, yes, they have multiple patient languages. If you go to the website, you should actually. I think they have like a language option there.
Hey, Dr. Hurley, Dan Dickerson, great to see you.
It's good to see you too.
Yeah, I had a general question. It's probably not clinically, it's some of these medications are over the counter, yes?
They are, and they can be prescribed. Both are true.
Right. So do you have any, I was just curious, your general thoughts on someone out in the world, not connected to medical care, buying some patches, do you have any general thoughts on their any kind of instructions for the general public, let's say, who are deciding to do this on their own?
Yeah. I would actually take the exact same instructions on the expected practice with DHS and have patients estimate the amount of nicotine they take in and then dose themselves accordingly. So it would actually be the same. The expected practice is written with the clinician audience in mind. So people who are better than me about graphics could probably like put it in plain language and, you know, make it in a way that's more patient friendly, but the actual core principles will be the same.
Yes, thanks.
Andy?
Hey, Dr. Hurley, this is Tucker.
Oh, hey, Tucker.
Hey, question about the dosing for nicotine replacement therapy. Every time I see it, it's with like cigarettes, packs per day or cigarettes per day. Is there any guidelines for people that are currently vaping?
There is.
Yeah.
So you have to know what they're vaping. So different vapes come with different strengths. So typically it's an internet search for what brand you're using, and then you take the brand they're using and based on the strength that they're buying, figure out how much nicotine's in the pod, then say how long does the vape last. So if somebody's got a 50 milligram pod and their vape lasts 5 days, then they are a 10 milligram a day smoker. They get the 14 milligram patch plus the 2 or 4 milligram grammalysis, which is supposed to be program. So that's how you convert vape pods to cigarettes per day, is just take the milligrams of pod, how long does the pod last, and that gives you the equivalent.
Awesome, thank you.
But unfortunately, because different pods are at different strengths, there is no like universal, like for me, I always have to search, right? Like I can never just assume. So unless somebody really knows, they're like, oh, it's a Juul 5%. Okay, now I have to go you know, like then I have to go figure it out.
Awesome. So it's just a milligram equivalent once you find out the milligrams.
Exactly. Andy?
When you was talking, it bring me to mind population that people don't talk a lot about, incarcerated people. They get thrown into incarceration, and some of them have been smoking for years. And I don't know if in California do they give them anything. I know in New York they only let them call 1-800 number, and they only get the patches. They are not. And then when you said the best medication is the one that the patient would take, they only get patches, and what they be doing with the patches is taking the nicotine out the patches and making teas and smoking it. So it is. Do you know if there's any ways where they could get the other thing? I know the gums will probably be something with security that they will not let them have because they could put them on doors and locks and stuff like that. But do you know any ways that they could get these medication, or in California, is it done differently?
So I'm unaware of any California carceral system that treats tobacco use disorder with medications. I would say, unfortunately. Now, I used to work in the LA County Jail, and for a while, actually, sort of tried to get to push access, but I could never get it through, you know, the pharmacy. Like they were just like, no.
Okay.
I do think, you know, compared to other things, varenicline's actually like, it's a pill, you can do mouth checks, right? Other than patches would stay on the skin, or gums, lozenges that, you know, can sort of play around with. It has an advantage to aligning with other medication treatments that people get when they're in custody. But I do think that any treatment does need to be contextualized to like what is acceptable for a custody setting. Because access to cigarettes and vapes is inconsistent in custody. It's not absent, people can smoke, but it's not, oftentimes you're not maintaining the same habit you would outside. While I think it's humane to treat tobacco withdrawal while people are in custody, it's even more important from my vantage point is to arrange tobacco treatment when someone's released, right? Because then they're going to go back to smoking. And this is a really key opportunity for somebody to sustain a quit attempt. And it's interesting, you get back, somebody's back out in their community with the same stressors, people, places, and things and situations, they'll start smoking again. You know what I mean? Like they'll go right back to the same behavior. So intensifying the treatment on release, in my mind, is, I mean, yes, we would want to give people treatment in custody. The reality is there's a fair amount of negotiation that takes to do that effectively. But what we could do is really emphasize the linkage to smoking clinics, like the, LA County runs a number of smoking clinics and a number of our treatment programs, the helpline medications that we sort of make sure and intensify on release that people are supported in potentially staying off of cigarettes if that's something they're interested in. Does that make sense, Andy?
Yeah, it does makes a lot of sense because they do quit in there because they are forced to. They don't have a lot of access to it. But as soon as they get released, the first thing they do is go buy a pack of cigarettes.
That's exactly right.
Especially because they're going back, depends how much long they were in there, they're going back to something that they don't know, and the anxiety comes and everything else. So they're looking for a release right away. And nicotine is legally, so it won't get them in trouble. So
that's right.
they're looking for that fix. And it could also, me thinking about it, it could also be a pathway to leading them back into stronger drugs because
Absolutely.
they get the nicotine and they want a bigger fix after they get the nicotine fix.
That's right.
So thank you for sharing that. It's a
Thank
very
you.
great insight.
So Ezekiel, you asked if there's still a shortage of varenicline. Not to my knowledge, right? There used to be, but I think the varenicline shortage is largely past and most people can access it now. What other questions?
Hello, Dr. Hurley. This is Duke.
Hello.
I was just wondering if you had any experience with adolescents with treating them with these medications.
Yes, the dosing isn't any different for adolescents. So the amount of, and more adolescents are vaping than smoking. So more often adolescents, I'm treating vape use disorder, in which case, same deal. How much nicotine you're taking in, dose with the patch, gum or lozenge, bupropion. Bupropion is off label for youth, but you can still use it. So it's not contraindicated in youth.
Thank you.
Yep.
And Brian, I apologize. I may have missed a prior training. But I had a question about CBT.
Sure.
In reading different studies and programs, there seems to be a wide variety of number of sessions, the duration of each session, how often sessions can be. Do you have any general thoughts on what would be a thorough CBT approach in terms of number of sessions and hours? And
so more than 4 and more than 10 minutes per session. That's going to be your threshold. One kind of unit, whether it's, let's say, a 15-minute session of CBT, is typically insufficient because tobacco treatment's a learning process. We sort of have to like trial and error things for most people. And so people need to like try a set of skills, come back, learn a set of skills. The Kick-Ash program that this study funded is a 6-session, like 45-minute to an hour, kind of depending on how quickly it takes to like how big the group is and how quickly it gets through the curriculum, is a 6-session, roughly 1-hour treatment that's designed for weekly. Does it have to be weekly? No, but when you start spacing out the sessions, there's more opportunity for kind of like unlearning. You know what I mean? Like, but the evidence on CBT is more than 4 sessions, more than 10 minutes a session. Like if it's less than 4 and less than 10, it really doesn't separate from like, I'll call it like just treatment as usual, right? More general kind of treatment. And the frequency, it's the frequency the patient needs. Weekly is probably going to be your kind of standard frequency. Less than that, as you begin to get less than that, you're probably losing effectiveness. Every 2 weeks is probably like not quite as effective. When you get to every month or every other month, at that point, it's almost like you're doing a new session every time anyway.
yes, thank you.
Yep. Anything else before we break? Brent, I think this might be the last kind of formal scheduled Kick-Ash program. And I think here in LA County, we're still trying to figure out how to keep this material going. But I just wanted to say thank you, particularly to Norma, Brianna, and the TRDRP team for all of the efforts to make these trainings possible. It's been a lot of fun.
Thank you so much as well. We appreciate the knowledge. I will let everyone know, I will send out the handout from today's conversation, and then also a recording of today's meeting. We do plan on putting on YouTube this recording of the ECHO webinar, and then the Kickash CBT that we were talking about a little bit ago. We plan on putting that on YouTube as well for everyone to see, and we will hopefully distribute that to everyone here on this meeting. Thank you.
Andy, is there anything else you wanted to ask?
Yeah, you mentioned something about happening in San Diego. Would that information be sent to us and stuff like that? I would like to attend.
I don't think it's actually in the handout, so I would do an internet search for California Society of Addiction Medicine and
Okay.
American Academy of Addiction Psychiatry.
I could also look up that information and add it to the email.
Perfect.
Oh,
Thank
that'll
you.
be great. Thank you.
You're welcome.
All right. It's good to see everybody. Take care.
Thank you.
Thank you.
Bye.